Previously, I discussed pressure assist control in a patient with relatively normal lungs. This time, I'm going to talk about pressure assist control in acute hypoxic respiratory failure. Tutorial 24, Pressure Assist Control, Part 2. Welcome back. This is the second tutorial on pressure assist control. The first tutorial looked at a patient with relatively normal lungs, and I discussed how to set up pressure assist control on the ventilator and the various parameters that are really important, starting with the airway pressure and the driving pressure. And I also described the problem of mirroring the alveolar pressure to the airway pressure waveform that you see. I talked about tidal volume variability, particularly with pressure assist, and pressure assist is the breath the patient takes that's not a controlled breath. I discussed crafting the pressure waveform and crafting the flow waveform, and then I explained why tidal volumes are low with very short and very long inspiratory times. This time we're going to talk about the patient with acute hypoxic respiratory failure and how they can be managed on pressure control ventilation. We're going to talk about increasing the inspiratory time and the gas distribution effects of this, and also the effects on airway resistance. We're going to talk about pressure control when hypoxemia progresses. I'm going to introduce the problem of transpulmonary pressure in pressure assist, and then we're going to discuss inverse ratio ventilation in the setting of pressure assist control. You'll recall that so far in this series of tutorials, we've had two patients with acute hypoxic respiratory failure. Frank, who was admitted with a community-acquired pneumonia that deteriorated to the disease that we call acute respiratory distress syndrome, ARDS, and he was treated with volume assist control after he was intubated. And the pathway that he followed was that as he developed more and more hypoxemia, his PEEP level was increased according to a protocol. Simultaneously, his respiratory rate was also increased. At the point where his airway pressure hit 30 centimeters of water, we started to reduce his tidal volume, and then I explained various different things you could do with him to try and get him through this problem of hypoxemia despite being apparently maxed out on the ventilator. Now, the other patient we've met so far is Carla. Now, Carla came in following an overdose, and she seemed okay, but she had a low GCS, and she started on pressure control ventilation on various settings that are fairly basic, but the whole pattern here was to target a tidal volume of 450 mils and to ensure that when she assisted the ventilator that her flow and pressure waveforms were correct for her, that she wasn't dys-synchronous with the ventilator in any way. This tutorial is about what happens when Carla deteriorates. Let's start with a little bit of revision. I want to review something that I covered previously, but I'm going to simplify it here just in case you hadn't seen any of those earlier videos. And this is the impact of increasing inspiratory time on gas distribution. And I'm going to show you a model of just two lung units, and the roundy bit there is the alveolus and the pink bit is the conducting airways. So the lung unit on the left is normal, it's very compliant, there's no problem. The one on the right has a ring around it to show that it's poorly compliant, it's diseased, it may be consolidated, there may be all kinds of stuff going on, there may be some water around it, may be compressed by pleural effusions. Now what happens here is we have our inward flow of gas going into the patient, and gas will always go along the pressure gradient. So it'll go from where it's in high pressure to where it's in low pressure, and the place that it's most likely to go is the most compliant lung units. So the gas just rushes into these most compliant lung units, and those poorly compliant lung units remain poorly ventilated. And this isn't great, and this is what happens when you give a volume cycled breath to somebody. The gas just goes in and that's it, and out it goes straight back again. But what we do in pressure control is we put a plug on the airway and we just hold it there for the duration of the inspiratory time. And what happens then is compliant lung units reach a stretch limit, and then there's a back pressure on them, and they squeeze the gas backwards by the Pendulluft effect into other compartments in the lungs and into these less compliant lung units that inflate and gas turns over in them. And so you get better overall gas distribution, better overall ventilation perfusion matching, better overall oxygenation. And a virtually identical phenomenon occurs with patients who have airway resistance problems. Now, pressure control is tremendous for patients with high airway resistance because, first of all, if they're breathing on their own and they're demanding a lot of flow from the machine, the higher the flow demand from the patient, the easier it is to match it by the ventilator. If you're in a flow limited state like volume control, that patient's sucking hard, but the flow is just not delivered to match their demands. So one of the great things about pressure control is the unlimited flow. But it's pretty similar. You can see here the second lung unit is partially obstructed due to increased airway resistances, maybe bronchospasm, it may be a local compressive effect, but irrespective, that lung unit has a long time constant because of increased resistance. And just like in the low compliance situation, flow will always go to the most compliant lung units, and the more resistant lung units are poorly ventilated. Again, if we put a plug into the airway and hold the gas there, what happens is the compliant lungs back pressurize, there's a Pendulluft effect, and gas is redistributed to lungs with higher resistance. I will point out though that there is a problem here because once those lungs units get inflated, they then need sufficient expiratory time to get the gas back out again. So if you're increasing the duration of inspiration, you really have to increase the duration of expiration as well to let that gas flow back out through those high resistant lung units. To summarize the situation of mechanical ventilation and airflow resistance, volume control guarantees tidal volume usually, but flow is limited. And this is a huge problem if the patient is breathing spontaneously. Not a big issue if they're paralyzed. And in many ways, paralyzed patient volume control just works really well overall. Now, pressure control, there is unlimited flow to meet demand, but the tidal volumes can be tremendously variable. They can be tiny, they can be enormous, and sometimes they go from tiny to enormous in half a dozen breaths. But if you increase the inspiratory time, you get overall tremendous gas distribution due to the Pendulluft effect, but there's a high risk of worsening gas trapping due to short expiratory times. Let's move back to Carla. Now, Carla has started to deteriorate. Remember, Carla has a polypharmacy overdose and came in comatose. And following intubation, she was reasonably stable for the first few hours with an IP of 12, tidal volume of 450, compliance of 37.5 mils per centimeter of water. Then her PaO2-FiO2 ratio started to fall. That means that she was becoming progressively more hypoxemic. Her arterial oxygen content started to fall and more oxygen was given, and her lung compliance deteriorated. Her chest x-ray revealed evidence of aspiration pneumonitis. Now, there are various things you can do to try and improve the situation, but be aware what you're really trying to do here is increase her mean airway pressure. And just to point out, on this particular diagram, we are mapping out mean airway pressure on the y-axis and inspiratory time on the x-axis. And you can see that the mean airway pressure increases progressively with inspiratory time. And this effect can be enhanced by increasing the respiratory rate. But keep in mind that there comes a point where Auto-PEEP emerges. In this picture, I have mapped out mean airway pressure against airway pressure on the y-axis and inspiratory time on the x-axis. And you can see here at this point of 3 second inspiratory time, 1 second expiratory time, that's a 3-to-1 inverse ratio ventilation strategy, that the mean airway pressure is a really generous 25 centimeters of water. However, if the patient has Auto-PEEP, and this is just 3 or 4 centimeters of water Auto-PEEP, what happens is that mean airway pressure drops off significantly. And the reason for this is that there is a fall in the driving pressure, and the fall in the driving pressure results in a loss of the area under the pressure time curve. So you've got to find the right balance for your patient of using an inverse ratio ventilation versus losing the tidal volume. And the tidal volume is important. I want to give you an idea of how most people would manage a patient like Carla as she deteriorates when you're using a pressure control and PEEP and inspiratory pressure strategy. We start off with a 1:3 I/E ratio, a PEEP of 5, and an inspiratory pressure of 10, and she's receiving 30% oxygen. So we're looking at pretty normal lungs here. Then as she becomes a little bit more hypoxemic, requiring 40% oxygen, we push the PEEP up to 10 centimeters of water, the tidal volume remains the same. And so as a consequence of that, the driving pressure is the same. And what we have now is a 1:2 I/E ratio to increase the mean airway pressure. As things deteriorate, we now increase the PEEP to 15. The compliance is falling, but we're hoping that our volume pressure curve will improve. We're still on a 1:2 ratio, and our plateau pressure is 25. Once we hit 60% oxygen, Carla is in real trouble. But the 60% oxygen pushes her PF ratio down below 100. And at this point in time where there is a worsening PF ratio and worsening dynamic compliance, we need to administer neuromuscular blocking agents to this patient. This will have a dual effect. One, it loosens up the chest wall to make the chest wall more compliant. It also stops the patient breathing spontaneously. And I think it's really important to understand that the concept that everybody talks about, that you got to keep plateau pressure at less than 30 centimeters of water and the tidal volume at less than 6 mils per kilo, this is a little bit of a myth, and I'll explain to you why. It's a good rule, but you really need to understand that this rule is really good for a patient who is paralyzed, like Carla is now, versus a patient who is not paralyzed. Well, this is a model that we're going to use for the next few minutes, and it's a pressure time waveform. And the pressure is on the left-hand side, and it goes from 0, that's the horizontal line, to plus 20 centimeters of water, and then below that to minus 20 centimeters of water. And Carla starts off with a PEEP of 5 centimeters of water and a plateau pressure of 20. That's our pressure limit. So the driving pressure is 15 centimeters of water, and our inspiratory time is 1.2 seconds. Now, if Carla were to take a breath, this is what you'll see. So you see her airway pressure curve, and you see her alveolar pressure curve, and her tidal volume is 450 mils. Now, I'm going to draw a new curve that we haven't looked at before, and that is the pleural pressure curve. And you can see here that the pleural pressure is slightly positive in expiration, and then it becomes significantly negative during inspiration. And the difference between the plateau pressure and the pleural pressure is the transpulmonary pressure, and that is effectively the stretch pressure on the alveoli, and it can be quite significant. And this is a normal situation where she's taking a decent tidal volume, her plateau pressure looks fairly normal, and we're not too bothered by what's going on because everything looks normal on the surface. However, in this situation, we're going to keep her on pressure control, but now she's getting quite sick. And so the PEEP is up to 10 centimeters of water. And here's our 30 centimeters of water pressure limit and our IP of 20. So let's see what happens here. We have our 1.2 second I time, and we're going to look at the airway pressure. And Carla is still breathing. Now we'll look at what we're looking at. So there's a lot to see here. The first thing that will jump out at you is that the tidal volume is exactly the same. And this is quite reassuring because you say, well, the tidal volume is only 450 and the airway pressure is 30 centimeters of water or less. So this is fine because this is what all the textbooks say. You need to limit your tidal volumes. But there's more than meets the eye. And the first thing that you've got to look at there is that divot in the pressure curve that goes from 10 centimeters of water of PEEP right down below atmospheric pressure, and then the airway pressure becomes positive, and that is not good. And let's have a look at the pleural pressure that matches this, and look at that huge big swing downwards in the pleural pressure, this huge almost valley of pressure that's being generated right down to minus 20 centimeters of water. And this is a huge drop off. So instead of what we had earlier on, we had a plateau pressure of 20 and a pleural pressure that was minus 10. Now we have a plateau pressure of 30 and a pleural pressure of minus 20 and this gargantuan transpulmonary pressure. And this is causing a dramatic amount of stretch on the lungs. Now, here is a situation where Carla is taking these huge whooping breaths. So she makes this massive inspiratory effort. There's a flow of gas, and the gas goes to the most compliant lung units. These lung units become grossly overdistended with this huge gasping breath, and potentially recruitable lung units are dynamically compressed. We talked about dynamic airway compression in a previous tutorial. On the surface, this looks okay because the tidal volume is 450 mils and the airway pressure is less than 30 centimeters of water, but there has been a dramatic increase in the dead space and in the partial pressure of CO2. The big mistake you make here is you either increase the inspiratory pressure or you increase the respiratory rate, or indeed even increasing the PEEP. All of these will have the impact of worsening this overdistension of these compliant lung units. The bottom line here is that gasping is bad. It causes dynamic hyperinflation and lung stretch injury. Sometimes this is called self-induced lung injury. There's an increase in the dead space to tidal volume ratio. There's worsening hypoxemia. And again, there is a temptation to increase both the IP and the respiratory rate, which will make things worse. So if you look at the last couple of tutorials, where we had two different approaches to similar disease. We had Frank, who had acute hypoxic respiratory failure, was treated with volume assist control, and he was given neuromuscular blockade with a moderate tidal volume and a fairly rapid respiratory rate that got his mean airway pressure up fairly impressively, versus Carla, who's on a modest amount of driving pressure with a decent enough tidal volume, high levels of PEEP, but only 15 breaths per minute, giving her a lower mean airway pressure and with worse oxygenation. So we're in this kind of bind. What do we do? How do we make Carla better with pressure control? And when you look at volume control, volumes are guaranteed, the flow is limited, the mean airway pressure can be increased by increasing the respiratory rate and PEEP. This may increase plateau pressure, and as a consequence of this, you have to lower the tidal volume. There may be dys-synchrony, but that will actually expose gasping. And there's a lot to be said for using volume assist control ventilation in patients with severe hypoxic respiratory failure, because you really have a fair amount of control of what's going on. Now, with pressure control, the tidal volumes are not guaranteed. They vary with pressure and resistance. Flow is unlimited, which is great if the patient is breathing, but that leads to problems with gasping. The mean airway pressure can really only be increased by increasing the inspiratory time or the PEEP, because increasing the respiratory rate causes auto-PEEP and a loss of tidal volume. And also the gasping problem is often missed. So let's have a look at how you can improve oxygenation in someone like Carla without increasing a respiratory rate like we did with Frank, by increasing the inspiratory time. So we start here now where we were at 80% oxygen with a inspiratory pressure of 15, a 1:2 ratio, and 15 of PEEP. The big mistake people make at this point in time is they just go up in the IP. And here she is on 100% oxygen, and we've crossed the Rubicon. We've crossed that red line where we know we're going to get severe stretch injury. So we've got to try and get that pressure down and improve overall gas exchange, and we'll do that by increasing inspiratory time. So by going to a 1:1 ratio, we now get back to 80% oxygen for the same level of lung disease. But we can make things better further. For example, by now going to a 2:1 inverse ratio, we can get her down to 75% oxygen. But see what the difference is here. We've left her plateau pressure at 30 and her driving pressure is now about 17, but we have dropped the PEEP. You have to drop the PEEP because of the problem of auto-PEEP. To get down to 70% oxygen, we're now at a 3:1 I/E ratio. The PEEP has gone right down to 5. Again, the true PEEP is much higher than that because of auto-PEEP. And the patient's on 70% oxygen. And we can go even more extreme here. We can go to 6:1 I/E ratio. This is severe inverse ratio ventilation, sometimes known as airway pressure release ventilation. And now we're down to 60% oxygen. And this is a good strategy for using. You use a slow respiratory rate, a long inspiratory time, and the patients oxygenate very well. Let's scroll back a little bit and look at PEEP. It's widely believed that if a patient is becoming more hypoxic, they always require more PEEP, and that is just not the case. Remember from previous tutorials that PEEP is used to both treat hypoxemia and to improve lung compliance. It also has a benefit in preventing lung injury associated with recurrent opening and closing of collapsed lung units, and this is known as atellect trauma. But it does have a downside. There comes a point where the PEEP is excessive, it causes excessive alveolar stretch, it causes an increase in dead space, and it may actually contribute to barotrauma. In this picture, we have a volume pressure curve for a patient on 5 centimeters of water of PEEP and 10 centimeters of water of inspiratory pressure. The volume pressure curve is quite flat, and the resulting tidal volume is 350 mils, and that translates to a dynamic compliance of 35 mils per centimeter of water. That means that for every centimeter of water of distending pressure, the tidal volume is 35 mils. This isn't good. It's quite low, and certainly this situation can be improved with some ventilatory maneuvers. So one of the things we can do, of course, is to increase the PEEP. So here we've set the PEEP at 10. The driving pressure is still 10, so the airway pressure is 20. And let's see what happens when we deliver a breath. And you can see here the volume pressure curve is so much better. You get this lovely upward inflection of the volume pressure curve, a far superior tidal volume of 450 mils for the same driving pressure, and that translates to a dynamic compliance of 45 mils per centimeter of water. And again, each centimeter of water of distending pressure gives you 45 mils of volume. So this looks pretty good, and this is a nice tidal volume for this patient, and that's our goal. But what happens then if the patient gets more hypoxemic and you go up on the PEEP? Well, the volume pressure curve may stay exactly the same, or we might encounter this situation. So here we have the PEEP at 15 centimeters of water, and the driving pressure is 10, so that gives us a pressure limit of 25, and let's send in the gas. And you can see here the volume pressure curve is much less favorable than previously. The tidal volume has fallen down to 400 mils, and the dynamic compliance has deteriorated to 40 mils per centimeter of water. Now, this is not a disaster. It's just interesting because clearly the lung is much less compliant at this particular airway pressure, and the baseline airway pressure from which you're building your breath is 15 centimeters of water. You might be happy with this, and it's fine. The distending pressure is only 25 at the level of the alveoli. This is generally considered safe, but it is a concern that the volume pressure curve is getting very flat at the top end of this breath. So let's return to this model and give you an example of how I think you should think about PEEP in patients on pressure control. And remember, the airway pressure is on the left-hand side and the I/E ratio is on the equivalent of an x-axis. And we're starting off with a patient on 30% oxygen. They're on a 1:2 I/E ratio, and the tidal volume is 450 mils from a driving pressure of 10 centimeters of water. The PaCO2 is normal at this stage. It's 40 millimeters of mercury, or 5.1 kilopascals. And this tells you that this patient is failing to oxygenate but not failing to ventilate. So this is purely hypoxic respiratory failure. And it's important to understand that from the outset that ventilation was not a problem. As you have gathered from our earlier discussion, things always seem to progress before they get better with hypoxic respiratory failure. So inevitably the patient's oxygen requirement goes up because the PF ratio falls. And what usually happens is that clinicians increase the PEEP in response to a deteriorating PF ratio. So in this situation, the clinician has increased the PEEP to 10 centimeters of water. The driving pressure wasn't changed, and the resultant numbers are as follows. For the driving pressure of 10 centimeters of water on a PEEP of 15, the tidal volume is 400 mils. The PaCO2 has now risen from 40 to 50 millimeters of mercury, or 6.6 kilopascals. So now we have evidence of deteriorating compliance and worsening ventilation, which to me is an example of overstretch and an increase in dead space to tidal volume ratio. You might be happy enough with these settings, they're safe, and you might leave the patient there, or you might increase the inspiratory pressure. But If the oxygenation deteriorates, normally what most people would do at this stage is go up on the driving pressure to get that tidal volume back to where it was. So by increasing the driving pressure up to about 13 or 14 millimeters of mercury now, you can see that the tidal volume is back to our target of 450 mils, but the PaCO2 has not changed. So even though the minute ventilation should have increased, the alveolar ventilation has not improved. And again, this is evidence of alveolar overdistension and an increase in the dead space to tidal volume ratio that cannot be improved by increasing driving pressure. And I will point out, it really won't improve if you increase respiratory rate, because that will increase Auto-PEEP. So what are your options here? Well, I think what you may have considered before going from 10 to 15 of PEEP was an alternative strategy of increasing the inspiratory time and reducing the expiratory time. So here we have gone back and gone from 10 to about 12 of PEEP and to a 1-to-1 I/E ratio. And in this setting, for a driving pressure of 10 centimeters of water or an inspiratory pressure of 10 centimeters of water, with a 1-to-1 ratio, with 12 of PEEP, we're getting our tidal volume of 450 mils, so that lengthened inspiratory time has increased the tidal volume. And the PaCO2 is 44 millimeters of mercury, or 5.8. So there is an increase in dead space, almost certainly caused by either the increase in the PEEP or the increase in Auto-PEEP associated with the longer inspiratory time. However, what's really important to note here is that patient's inspired oxygen tension with these deteriorating lungs has reduced to 40% from 50%. So the patient is oxygenating better at this lower PEEP level and ventilating better at this lower PEEP level with the longer inspiratory time. So I do think it's something you need to consider. You need to be very careful of I/E ratios and high levels of PEEP in pressure control. And it's my view that you're better off using modest levels of PEEP and longer inspiratory times if you really want to get better oxygenation and preserve ventilation. I'll just show you a few screen grabs of a patient who's on pressure assist control. And you can see here, that's the I time, the E time, I, E, I in. This patient's on a 1-to-1.6 I/E ratio. And you can see here that flow stops at the end of inspiration. So as inspiratory flow goes in, it hits that point and then the patient immediately exhales. So this is perfect. This is the way you want to see it. Now we're going to put this patient on a 1-to-1 I/E ratio. And now let's see what happens here. The I time is long, the E time is exactly the same. So you have a 1-to-1 ratio. And this is the point here where the flow stops, because the patient's lungs are exactly the same. The flow stops at this exact point, and now we have an inspiratory hold. And these yellow boxes represent the inspiratory hold. And now, during this time, we're getting lots and lots and lots of gas distribution. In this situation, by the way, the mean airway pressure is 10 centimeters of water. It's quite low. This patient is only on a PEEP of 5 and a driving pressure of 15 above that. And now we're going to move to a 3-to-1 I/E ratio. So you can see here, long inspiration, short expiration, 3 seconds of inspiration versus expiration. If you're on 15 breaths per minute with a cycle time of 4 seconds. And again, here's where flow stops, and we have these big boxes representing that long inspiratory time. And overall, this will really improve overall gas exchange. And in this particular case, the mean airway pressure is now about 12.5 centimeters of water. This is obviously a lot less than Carla's one would be because of her extremely diseased lungs. Now, here's the patient who's on 15 centimeters of inspiratory pressure, a PEEP of 10, and an inspiratory time of 2 seconds. So you can see there's something wrong here. And this is the big problem with using long I times. This is a terminal upstroke. And this is what you see in some patients when they start to breathe again. Normally, one exhales immediately after inspiration. And at most, inspiration only takes a second. Hence, the patient always wants to exhale. And this is what you see when the patient tries to exhale in a pressure assist situation and the breath is being held in the lungs. The patient is essentially exhaling against the plug in the airway, and the airway pressure goes up and you get this terminal upstroke. And this isn't great, and this is caused by the inspiratory time just being too long. The breath is going on too long and the patient is trying to exhale while flow is still being paused or is still being delivered in the lungs. Now here we have a patient on the same settings, IP of 15, PEEP of 10, inspiratory time of 2 seconds, and I've drawn out the inspiratory time there. Let's see what happens. Oh wow, there's something seriously wrong here. The patient is exhaling at the end of inspiration, even though there's a planned 2-second inspiratory time. The pressure spike has exceeded 3 centimeters of water, which is pre-programmed into most ventilators, and at this point, the patient's ventilator will pressure cycle to expiration. So in this situation, the breath has gone on too long for the patient who has exhaled and pressure cycled the ventilator. Let's summarize these points. Pressure assist control is really effective for increasing mean airway pressure by increasing inspiratory time, but it is part of a paradigm where you need to reduce your PEEP to maintain tidal volumes. That tidal volume should always be your goal. You can't let it drop off because that's a huge component of your mean airway pressure. It's also very effective at improving gas distribution by Pendulluft in situations of low compliance and high regional resistance. Spontaneous respiration is comfortable as it is flow unlimited, but there is a high risk of expiratory dys-synchrony if the expiratory time is too short, and there's also the potential for the patient gasping and having massive transpulmonary pressures that you don't recognize because you're stuck in a pressure limit of 30, tidal volume of less than 6 mils per kilo mindset. Auto-PEEP is a problem with all strategies that use pressure control and must be carefully monitored. Let's review this tutorial. This was the second of 2 tutorials on pressure assist control, and I concentrated on patients with acute hypoxic respiratory failure. I started off with a discussion about the value of prolonging inspiration and the Pendulluft effect, where gas gets redistributed during a long inspiration to areas of lower compliance and higher resistance. Then I went on to discussing the use of pressure control as hypoxemia progresses and the strategies that people tend to use. I discussed in the middle of that gasping and the problem of patients taking huge breaths in early ARDS and the problem with gas trapping and stretch injury to the lungs that's sometimes known as self-induced lung injury. I also discussed the value of considering transpulmonary pressure in pressure assist. We then went on to discuss inverse ratio ventilation in pressure assist control ventilation, and then finally I discussed expiratory dys-synchrony during long inspiratory times in pressure assist control. Next time, we'll move on to another mode of pressure control ventilation, and that is synchronized intermittent mandatory ventilation pressure control. And I'll explain how to set up this mode of ventilation, why it's a bit different from volume control SIMV, and why you may or may not decide to use this particular mode of ventilation. I'll see you then, and I guarantee you'll learn something. Well, that was the end of 2 tutorials on pressure assist control. Next up, I'm going to talk about synchronized intermittent mandatory ventilation with pressure control, SIMV PC with pressure support. If you're enjoying these tutorials, don't forget to subscribe on YouTube, and you can follow me at ccmtutorials.org. I'll see you then.